I'm Dr. Laura Rogers. I am a professor in the Department of Nutrition Sciences. I'm also an internal medicine physician and obesity medicine physician in the weight loss medicine clinic. My research focuses on exercise promotion and benefits in chronic disease populations, especially cancer survivors. And Dr. Reddy has very nicely set up the rationale for why it's important for us to discuss diet and exercise after pancreatic cancer surgery. And what I'm going to do is I'm going to start out by discussing some general guidelines around diet and exercise, and then try to explain how this information informed the design of a pilot research project that we're doing that is being supported by the Reed Foundation, and we hope to launch the participant recruitment in mid-June if possible. I have no conflicts of interest to declare, and I've already mentioned what we're going to be talking about. I do want to acknowledge Dr. Wendy DeMark-Winifred and Laura Rutledge, who's here, who shared some of the diet-related slides with me for today's presentation. Over 53,000 Americans are diagnosed with pancreatic cancer annually. The pancreatic cancer mortality rates in the U.S. are increasing. 80% of pancreatic cancer survivors present with weight loss, and weight loss is further exacerbated by treatments and disease progression. As already mentioned by Dr. Reddy, the pancreatic cancer experience is the perfect storm for developing weight loss, cachexia, and sarcopenia, which is associated with poorer quality of life and increased morbidity and mortality. One of the contributing factors is the lack of digestive enzymes, especially after pancreatic surgery, which can cause malabsorption and steatorrhea. You add to that the fact that they're anorexic and they have decreased intake. You add to that the increased metabolic nutrient consumption alluded to by Dr. Reddy, and you have a perfect storm for significant impacts on body weight. Lay on top of that the additional possibility of developing diabetes, with almost a quarter of patients who undergo pancreatic resection developing diabetes after their surgery. So this was a study that showed that preoperative sarcopenia is an independent prognostic factor in resected pancreatic ductal adenocarcinoma in patients with a BMI greater than 22. And since Dr. Reddy has so nicely covered this topic, I'm going to move quite ahead to save us a little bit of time. So diet is a critical component of pancreatic cancer survivor care, and the goals of that nutrition therapy are to prevent or reverse nutrient deficiencies, preserve lean body mass, help patients better tolerate treatments, minimize nutrition-related side effects and complications, maintain strength and energy, protect immune function, decrease the risk of infection, aid in recovery and healing, and maximize quality of life. Diet counseling. There are a few recommendations specific to pancreatic cancer survivors currently. So most of what I talk about will be a healthy diet for all cancer survivors used as a foundation. Counseling, especially for those individuals who are particularly ill after the surgery, is best delivered by a registered dietitian with certification in oncology nutrition. To start with the foundation, which is the healthy recommendations for all cancer survivors, the American Cancer Society has articulated these guidelines, and it is to achieve and maintain a healthy weight. This particular guidelines team focus on weight loss, promoting weight loss, but obviously in the pancreatic cancer patient, we want to promote a healthy weight. But if the individual is obese and you're trying to promote weight loss, you would limit high-calorie foods and beverages, and also increase your physical activity. And I'll talk a bit more about these recommendations related to physical activity, and that is that the individual avoid inactivity, resume normal activities as soon as possible after their diagnosis, exercise for at least 150 minutes per week, and include strength training at least 2 days a week. As far as a dietary pattern that is recommended, is that the individual eat a diet that is high in vegetables, fruits, and whole grains, and choose foods and beverages in amounts that achieve and maintain a healthy weight. Limit processed and red meat. Eat at least 2.5 cups of vegetables and fruits per day. Choose whole grains instead of refined grain products. And if you drink alcohol, drink less than or equal to 1 drink per day for women and less than or equal to 2 drinks per day for men. Try to obtain your nutrients through diet first, and Dr. Salvador is going to talk a bit more about supplements, and consider supplements only if a nutrient deficiency is biochemically or clinically observed, and there will be some patients who, after pancreatic surgery, will develop a surgical induced deficiency that may have to be treated. I want to make 2 comments, one specifically about red meat and one about alcohol. Red meat is considered a carcinogen. It has been associated with the development of several cancers. Unprocessed meat is the worst offender. And this just shows the example of one study, which was a meta-analysis where they took 2 very large studies and combined the data into one and looked at the risk of cancer mortality for each single serving of red meat per day. And what they found is that if it was not processed red meat, there was a 10% increase in the risk of cancer mortality and for each serving per day. And if it was processed, it was a 16% increase. It is recommended that the individual limit the intake of red meat, especially processed red meat, and to not eat more than 8 ounces per week. Alcohol has been associated with an increased risk of several cancers. In this particular figure by a group out of the UK, a larger circle indicates a greater risk association. Pancreatic is not here on this list. However, if the individual engages in heavy drinking, which defined as at least 21 drinks per week, then there is a direct association or significant association with a risk of pancreatic cancer. Head and neck cancer patients, survivors should not, it is advised they should not drink any alcohol whatsoever. So what are some common side effects during and after pancreatic cancer treatment that can influence the nutrition or the dietary recommendations? And this is not a complete list, but these are some major side effects, including the anorexia, nausea and vomiting, diarrhea, bloating, colitis, enteritis, malabsorption, pain, mouth ulcers, and possibly diabetes. And here are some strategies that may be helpful when talking to patients about diet at this point. Small, frequent meals, avoiding greasy foods and or foods with strong odors. Drink plenty of fluids, and sometimes just changing the temperature of the fluid or the foods can make it more palatable for the patient. Try avoiding the milk and dairy products. Consume potassium-rich foods if they're having diarrhea. Individualize your dietary counseling according to the patient's pattern of appetite. Introduce new foods or supplements at times that will optimize acceptance. And if necessary, use the pancreatic enzymes or lactase products. If they have mouth sores or mucositis, here's some possible strategies for dealing with that. Mix foods with gravy or sauces to make them easier to swallow. Use a straw to direct the fluids away from painful areas of the mouth. Try numbing the mouth with ice chips or popsicles, and avoid alcohol, caffeine, and irritants such as citric acid, tomatoes, and hot peppers. For those individuals who are undergoing chemotherapy, they may be immunocompromised, and so it's important to use safe food handling practices. So it's good to encourage patients to wash all fruits and vegetables well, wash hands in food preparation services before and after preparing food, especially raw meat. Thaw meat in the refrigerator, not on the counter. Cook meat and eggs thoroughly. Avoid raw shellfish and use only pasteurized milk and cheese, and be careful when eating out. And then some patients may require some additional nutritional supplementation, and here's just some examples. And of course, if this is the case, the patient will be most probably counseled by a registered dietitian. Exercise. So exercise has been associated with a reduced risk of developing cancer as well as improved outcomes in some cancer types. Most of our data is available for prostate, colorectal, and breast cancer. We don't have a lot of data on how physical activity affects cancer mortality post-pancreatic cancer. But here are some of the pathways it is hypothesized that physical activity is linked with improved cancer outcomes after a diagnosis. Physical activity can influence these pathways either directly or indirectly through its effect on adiposity. And although this framework was published within the context of obesity, the fact that sarcopenia is a relative adiposity in that the lean muscle mass is much less than the fat mass relatively, the adiposity still makes a difference or is still relevant in this case. So physical activity can be linked to cancer risk through its effect on sex hormones, immune function, inflammation, and the insulin axis. We also know that cancer and its treatment can have several biologic, psychobehavioral, and functional detrimental effects, which can all contribute to poor quality of life. So with the cancer diagnosis and the treatment and the inactivity that may come with that, the patient may have reduced muscle mass, reduced muscle strength, increased inflammation, increased psychological distress, and then the decreased physical functioning. And it was interesting to see when Dr. Cavalli was talking about the most frequent symptoms on the distress thermometer. We're talking about functional mobility, we're talking about fatigue, so we're talking about things that do relate to these effects. So physical activity has been shown to prevent or reverse or at least attenuate many of these detrimental effects. So this is a recent meta-analysis in which they took a number of different studies and pooled them all together to see if physical activity before diagnosis of cancer and then physical activity after diagnosis, if these were associated with a reduced risk of cancer mortality. This top figure here shows the post-diagnosis physical activity, and this solid line is the one to really concentrate on. I know there's several lines there, but that's the one we're interested in right there. And it shows that as the person's physical activity level went up, they had a reduced risk of cancer mortality. If they looked at pre-diagnosis, which is this one down here, it shows almost a plateau here. The thing that's, I think, important here is that to translate this right here, this 10 and this 10 right here, that's about 2.5 hours of walking per week. So that's very consistent with the guidelines of 150 minutes per week of moderate intensity exercise. Most of this data was drawn from breast, prostate, and colorectal cancer patients, and so it would be really nice at some point to have further research around the relationship between physical activity and survival in pancreatic cancer patients specifically. So in spite of these benefits, we do know that cancer survivors are less physically active than healthy adults. This is the data from the Behavioral Risk Factor Surveillance Service out of the CDC. They do not report this data for pancreatic cancer specifically, but we do see that if this is a normal, 48.7% of healthy adults were engaging in the recommended amount of physical activity. And then when they looked at the different cancer types, you can see that all these cancer types were falling below that level. Skin melanoma was not very, was pretty close to that, which kind of makes sense. But all the rest were low, and we would expect that the same would be true for the pancreatic cancer survivor as well. We also know from another recent study that the cardiorespiratory fitness and the muscle strength for pancreatic cancer patients is lower than that of the healthy reference values. And then Dr. Reddy already talked about the stair climbing, which I thought was an elegant study, so I'm going to move beyond that. So clearly there is a role for physical activity after cancer diagnosis, including in pancreatic cancer patients. And the current recommendations are for the cancer survivor to be assessed for their current physical activity level and limitations to activity level, and encourage the physical activity as soon as possible, and tailor recommendations to abilities and preferences. And the general recommendations are that they engage in at least 150 weekly minutes of moderate intensity, or if they're doing vigorous intensity, their goal is 75 weekly minutes. Do strength training 2 to 3 days per week, and stretch on the days they do exercises. And as we talk about the pilot project, what I want you to understand is these are the goals that we're going for, but we also understand that these individuals are going to have limitations on what they can do, and they need tailoring and individualized recommendations from individuals who are specifically trained for providing that. So the NCCN survivorship guidelines also suggest that there are individuals who, for example, should not exercise at least temporarily if they have severe anemia, if they're immediately post-surgery, if they have worsening physical condition or an acute infection. It might not be a good idea for those individuals to engage in some regular physical activity. There are individuals who might need referral. For example, if they have musculoskeletal issues or bone metastasis or poor bone health, they might benefit from a referral to a trained exercise professional. And this may also be true if they have, for example, an ostomy or lymphedema. So one of the points I want to make about the referral is there is a difference between a physical therapist and an exercise physiologist, and there's also a difference between could be a difference between a personal trainer and an exercise physiologist. Not all personal trainers are exercise physiologists or have an exercise science background. And so I think it's important, if you're going to do a referral, that you understand the educational background and the prior experience of the individual who's going to be working with your patient. A number of cancer survivors are going to be fine, but there are going to be some that have some of these very, very significant comorbidities that are going to need someone with a bit more expertise. So a little advertisement for just a minute. We do have two individuals at UAB who are certified by the American College of Sports Medicine as cancer exercise trainers, and they do have master's level degrees in kinesiology. And we do have individuals, cancer survivors can get exercise sessions from these individuals for an out-of-pocket expense. And I do have business cards for our lab if anybody wants to pick those up for your patients as well. So we did a pilot project, but Dr. Arthur was a postdoc in our lab, and we did a needs assessment with pancreatic cancer survivors. And what we did is we identified 50 survivors through the UAB Cancer Registry, and we had a 72% response rate. 50 was how many we ended up with, which is a 72% response rate. And their mean age was 69, so you can see these are older. 84% were white, 57% were women. The median driving time to UAB was 90 minutes and ranged from 12, I think that actually meant 12 minutes to 72 hours. I apologize for that. Not 72 hours. That was 72 minutes, excuse me. So anyway, some of these people live a good distance from UAB, and so a supervised exercise regimen is not going to be feasible for those individuals because they just can't travel 3 times a week into UAB for the supervision. Because most of these patients were, you can see the mean months since diagnosis was 13, so most of these patients were the early stage. We also had enrolled those who were resectable, which is another reason why that was the case. But 69% said they would have been interested in diet and physical activity programming during the 3 to 6 months post-surgery. They anticipated that their barriers would have been physical, personal, the travel distance, and the cancer treatments. And their most frequent anticipated facilitators was they really wanted to be made aware of these programs, and they needed them to be easily accessible and home-based. All this information went into our thinking around the research study that we're going to do. So when we asked them, do you want to be supervised? 50% of them said no, they'd rather just exercise on their own. 30% said yes, and 20% didn't have a preference. And then when we asked them, where do you want to exercise? Most of them, 56%, wanted to exercise at home. And then we asked them, how about exercising at a place like UAB, and only 8% really wanted to do that. So we also asked them how they preferred to receive exercise and diet counseling, and we found that 34% of them wanted in-person counseling. That was the most preferred option. And then telephone, other, and no preference was about the same. Diet counseling, 48% of them wanted it in person. And then you can see the other options down here. Yes?
Can you flip back one more? Okay, so,
okay.
At any rate, most of the physical exercise through UAB is not covered by insurance.
That's correct.
So that's why your number is so low.
Which number? The one under exercise supervision?
Right.
Yes. Yes, and that's a struggle for those of us in the field, is that we know this would be really important for patients to go into something similar to cardiac rehab, only cancer rehab, but we haven't yet been able to convince the third-party payers to pay for that same paradigm for cancer patients, but we really need it. Thank you for pointing that out.
And I guess that's even more represented in lower socioeconomic settings.
Definitely.
Individuals. So you could say that poor people were unhealthy.
It's definitely an issue, yes. So all of this information informed this pilot project, which I'm going to talk about. We also know that there are several hundred studies in a variety of cancer types that have shown the benefits of exercise after cancer. Most of those studies have been done in breast, colorectal, prostate, some hematologic, and some GYN cancers. At this point in the literature, to my knowledge, there is only one randomized controlled trial of exercise in pancreatic cancer patients specifically. There appears to be one that's ongoing because they published their study design, and there are several that are registered on this. I will point out, this is a federally mandated website where all clinical trials have to be registered at the time, at least by the time they start recruiting. And right now we have approximately, looks like from my search, about 6 studies in pancreatic cancer that are ongoing. Excuse me. But in the one that we do have published, it was a home-based walking program. They basically were given some information and sent home to walk. It's post-surgical resection. They enrolled during hospitalization or at first post-op visit. And they were able to show that the intervention reduced fatigue and pain and improved physical functioning and mental health composite score. So we are proposing, and will hopefully launch in June, a study which we want to test feasibility and the preliminary size of the effect of exercise in what we call a 2-arm randomized controlled trial, which basically means that patients will be randomly assigned to either get diet only or diet plus exercise. Individuals who are randomized to diet can do exercise if they want. We're not preventing them from doing that. It's just that the exercise group will get additional support from our cancer exercise trainers. And what we're going, and this will be for individuals who are, they're going to have surgery for resectable pancreatic adenocarcinoma. And we're going to do assessments pre-surgery, post-surgery, in the first few weeks post-surgery. We'll randomize them at that point and then start the intervention, and we'll do assessments again at 3 months and 6 months. We're going to do this counseling by, we're going to loan them a tablet that has HIPAA-compliant Skype-like software on it. So the individual and the exercise specialist can speak to each other face-to-face, and the exercise specialist or a cancer exercise trainer can also, through that mechanism, watch the patient do their resistance training with we're going to use resistance bands for the resistance part of that, to make sure they're using the proper form and help them troubleshoot. Their cancer exercise trainer can watch them walking on a treadmill if they want them to, but they'll probably just have them be walking in their neighborhood, or but try to help them set goals and try to help them, because as we learn from working in a different group, the head and neck group, they're going to have weeks when they can do really well and weeks when it's not going to be so good, and it's going to be kind of like this, and so they're going to be able to every week work with the patient on tailoring that. Both the diet and the exercise counseling will be provided using this tablet, and both will occur every week. One other thing I need to mention is that the patients who receive exercise will wear a Fitbit, and both the patient and the cancer exercise trainer will be able to see what the Fitbit's measuring, so they can give them some additional feedback. And we're going to measure feasibility, performance status, quality of life, objective physical functioning, and then some of these outcomes which will help us understand what role physical activity might play in things like cancer treatment completion rates, which is something that Dr. Reddy mentioned, perhaps survival and recurrence, and markers of that, their physical activity behavior, immune function, fatigue, pain, body weight, sarcopenia, and blood samples. We're going to actually store blood samples in such a way that we can do some additional studies related to some epigenetic effects and things like that later. So this is just for those of you who might not be familiar, this is a schema for showing how a patient might flow through the study. And this is at the time of diagnosis, then they'll be screened and enrolled. And then just before surgery, they'll get their first assessment. Here they'll have surgery, and then after surgery, they'll get another assessment. And then we'll randomize them into diet plus exercise or diet alone, and then we'll do the assessment again at 3 and 6 months, and the intervention is 6 months long. We wanted to do a pre-surgery and a post-surgery assessment so that we would know kind of what their baseline was before surgery. So I think that a couple of things make this study unique. You know, it's been, you probably could tell from, to me, it's clear from what's been said that nutrition is really the foundation, and everybody has got to needs to have standard of care nutrition. And so we wanted every patient to get that as a foundation. So that is not something that's always done in the exercise and cancer trials. We're going to integrate the fitness bracelets with the tablet-delivered counseling, and we're doing these pre and post-surgery measures, and we are measuring some outcomes that could potentially link poor physical performance or even the sarcopenia to the prognosis. And here are co-investigators, which I'd like to acknowledge, as well as the funding from the Reed Foundation. That was just a reminder. And are there any questions?